We're going to be discussing Chapter 8, Assessing General Status and Vital Signs. The Chapter 8 objectives include describe a survey of general health status, assess accurate vital sign measurements, assess for the presence of pain as the fifth vital sign, describe the findings frequently seen when assessing general status and vital signs in individuals, including the adult and older adult, and differentiate between normal, abnormal general survey, and vital signs. So our general survey begins with the very first time that you encounter the patient. When you walk into the room, you use your observational skills. What kind of things are happening in the room? Is the room quiet? Is the TV on? Is the patient sleeping? You're going to see a lot of those things just walking into the room before you even touch the patient. A lot of times, if you're looking at the patient and maybe the patient is sleeping or something like that, that gives you some clues about their health status. So I always begin with non-invasive vital signs first. We do more temperature, then pulse, counting and respirations, and then we do the blood pressure last. These vital signs are done regularly throughout the stay because they provide information about the cardiovascular system, neurological system, peripheral vascular, and respiratory systems that can help you identify even subtle changes about the patient's health status. When we observe the clients and the environment before interacting with them, maybe we see if a patient has the TV on very loudly, and maybe there are some issues with hearing. Maybe if the patient has a room that's dark and quiet with no TV and no music, maybe that the patient is trying to sleep or rest. So there can be different things that are happening there. We always observe the patients visually for their skin color. If the patient is pale or has cyanosis to the lips, that might give you some indications about what's happening with the patient. Their hygiene, is their hair brushed? Are they sitting upright in the bed or sitting upright in the clinical setting? That tells you a lot about that patient. If the patient has curvature of the upper part of the spine, especially older adults, that might lead you to think of some kyphosis. Maybe if the patient has lateral curvature in the posture, maybe helping you to identify some scoliosis. So the posture is very important. Just the same as the gait. When you're observing somebody walking, you can identify, is there any gait issues, stumbling, things like that that might lead you to think that there's concerns with musculoskeletal issues, or even neurological issues sometimes can be seen in the gait. Physical development and body build, apparent age, gender, all those kind of things, you can observe some of those things even before you touch the patient. Another thing that we'll identify, again, like we were talking about before, is sometimes their speech. When you're asking patient questions and they're responding to you, you can listen to their speech. If their tone and speech is clear or garbled or whatever, it tells you sometimes about that patient. Their facial expressions, is their smile symmetric? Those kind of things can help you identify any abnormalities. And even before you touch the patient, we look for obvious signs of distress, maybe grimacing from pain, or maybe the patient is short of breath, and you can see that very obviously even before you touch the patient. So some subjective data we might ask to identify and note any abnormal findings. So your name, phone number, age, date of birth, that demographic data, your history of present health concern, like we had talked about in discussion of the subjective data chapter. So we identify in relation to general status. abnormal vital signs, fever, difficulty breathing, maybe a high pain severity. It's important to note when you're dealing with general status maybe and blood pressure vital signs, any history of the blood pressure. What is the trend? What is the blood pressure typically for that patient? The values of normal does not always apply to all patients. That different patients have different baselines of this information. Maybe some arrhythmias, palpitations, things like that. You might have to ask the patient about those things. Medications taken and allergies are always questions that we ask. When we're talking about vital signs, we want to know what their family history is. We talked about this when we were talking about subjective data chapter. That those genetic diagnosis of heart disease, diabetes, thyroid, high blood pressure, cancer, other family histories are important to note when we're talking about patients' care. Lifestyle and health practices, alcohol, tobacco, diet, and exercise definitely impact a patient's vital signs. So when we prepare for the general health status, we can do a lot of this in observation of the patient's posture and movements. Is the patient comfortable? And we will explain the procedure to the patient. What are we going to be doing? And when we're taking vital signs, how we're going to do that. What equipment would you need to take vital signs? Well, if you're going to take the temperature, then you'll need a thermometer of some type. If you're going to take the blood pressure, a lot of times, if you're taking a manual blood pressure, you'll use this sphygmomanometer. I know that's a mouthful. Or you'll use a Dynamap or electronic blood pressure equipment. You also need your stethoscope to do the blood pressure, especially if you're doing it manually. And you'll need to watch with the second hand because when we count our radial pulse, you need to count for 30 seconds and multiply times 2. And as well, you're going to count the respirations for 30 seconds and multiply times 2. When we are looking at the general impression survey, we're going to observe physical development, the body build, fat distribution. There's a wide range of body types that are out there, different patient populations. We may have a patient who is very thin and frail, a patient who is average build and appropriate fat distribution, and then we might have more obese patients and morbidly obese patients. So it's important to note this as this will affect how you care for the patient and your possible assessment procedures you're going to provide. Just as well for height, looking at what your average height is for that patient, that has to be accounted. For symmetry, we look at the left and right side of the body and look to see if it's proportional. So we're looking at symmetry in the shoulder height and the hip height, for facial symmetry, for raising eyebrows, things like that. If there is asymmetry, typically there's a reason for that. And so that would be something that would be important to note when you're observing. We look at the patient's actual age with their appeared age, and sometimes if patients have been sick for a long time or have been exposed to some diagnosis, that they may appear older or younger than their stated age. We're going to always observe the skin color. There is no color that is appropriate for ethnicity, because that really doesn't define a color. We need an actual skin color, such as light to dark beige, pink, tan, brown, or olive. There is no, in this day and time in our society, there is no one color that defines everyone in that ethnicity. So that is not an appropriate description. Again, when you're looking at posture and gait, We look for rhythmic gait with coordinated arm swing, with full range of motion in your arms and lower extremities. So that is a part of your general impression. Some of the abnormalities that we might identify and things that I've talked to you about is malnutrition or frailty, obesity. If you have the smaller stature with dwarfism, or maybe with the larger features like acromegaly. Um, and gender and sexual development is something that you may deal with more in pediatrics. In most of the older adults, that is the development may not necessarily be the issue, but there is some things with hormone imbalances that we do deal with adults. We would also encourage you to understand that there are people who identify differently as far as their gender than what is stated, possibly on their record. So you want to handle those things in a very respectful way and always ask questions if you are not sure. So as far as skin color, there are different colors that may lead you to believe that this is connected to the patient's health status. For example, if somebody has pallor or they're pale, maybe they have anemia or low blood cell count. If they're flushed or have some erythema, some warmth, redness in the skin, we might relate that to maybe them having a fever. Yellow skin in that light skinned patient or yellow sclera, you might identify that with jaundice. So be thinking about how these colors can help you identify the health status of your patient. So posture and gait, we talked about some of those postures, lordosis, scoliosis, and kyphosis. And lordosis, that is a lower curvature of the spine, and we relate that a lot of times with the pregnant female. When we were talking about the general survey as well, we discussed earlier about the symmetric facial features. Well, if somebody has asymmetry in that facial feature, maybe in the lower part of the mouth, we might identify that with a stroke. If there is a droop in the forehead and um, the mouth unilaterally, we might relate that to more of Bell's palsy. So we'll talk further about diagnosis and related to what you're observing with these patients. When you are talking to the patient, it helps for you to know, can the person see you? Can they see what they're doing? Can they see better in one eye versus the other? So we're always going to talk to them about that. Same thing with hearing. When you are asking your patient questions, are they responding to you? Are they answering your questions in a clear speech? That is important to know. When we're assessing for any type of distress, we want to make sure there's no obstruction to the nose and throat, that the patient has a patent airway. So we'll assess their nostrils and hopefully they have that ability to swallow. So like we talked about before with vital signs, we will do the temperature, the pulse, the respirations, and then the blood pressure. So in the temperature, be aware that the temperature increases with strenuous exercise, stress, and possible ovulation. The lowest temperature is early a.m. So when you're taking your temperature for your patients in the hospital setting, you might notice that they have a lower temperature first thing in the morning. You need to know that hypothermia is connected to a temperature that's less than 96 degrees and hyperthermia is greater than 100. So these temperatures might be related to other diagnoses and you would be asked to know those. So when you're taking the oral temperature, which is what most of the time that you're going to be doing in the hospital setting, you will practice that in the lab. but you're always going to use a cover on that thermometer that's disposable. You're going to have the client put the probe underneath their tongue and close their lips securely around it. If you're looking at the tympanic or the temporal temperature, depending on the facility, you may use either one of these depending on the facility or the patient. So you need to know the tympanic is the probe goes into the ear, and then temporal is crosses across the forehead and then over the temporal artery to a point behind the ear on the mastoid process. Very frequently, if your patient is not able to do an oral temperature, we might do axillary temperature. So you need to be aware that the axillary temperature is 1 degree lower than the oral temperature. So there is a difference. It's very important to document what route you're getting the temperature, so that way you can see if there's a difference or a change or what the trend is. Typically, the rectal route is only used if there's no other route as practical. Your pulse is the heart contraction, the ventricular heart contraction, and that's felt in the radial pulse. You can feel that along that artery or peripheral pulse. So some of the pulse sites include apical, radial, and pedal, and these all should correlate with that ventricle pulse. So when you're measuring the pulse, you use the 2 middle fingers, you lightly palpate the artery. Do not obliterate, you just lightly palpate. You're going to count for 30 seconds and multiply times 2. The normal range is 60 to 100 beats per minute. Less than 60 is considered bradycardia. Greater than 100 is considered tachycardia. And there are some reasons why somebody might have tachycardia or bradycardia, so you want to be aware of those. Some of the reasons why somebody might have tachycardia could be fever, stress, dysrhythmia. If somebody is exercising, things like that, that they might be tachycardic during that exercise. When you're measuring respirations, you're going to observe the chest rise and fall. The respiration is an inspiration and expiration. You're going to count the rate for 30 seconds and then multiply times 2. The normal range is between 12 and 20 breaths per minute. So it's always better to count when the patient is unaware, because if they are watching you, then they are going to manufacture better breaths. That's just the way people work. So you can, while you still have your hands on somebody's radial pulse, you can start counting their respirations as if you're still counting the radial pulse. And the client may continue to be unaware. When you're watching respirations, you can assess for rhythm, depth, and effort. Are the breaths labored or unlabored, etc. is very important. Are they shallow? Are they even and unlabored would be the best finding. So during the blood pressure, we understand that your blood pressure is systolic and over diastolic. So your systolic blood pressure is the blood pressure in the arteries when the ventricles are contracted. That is the highest level of pressure. The diastolic blood pressure is the measurement in which they are relaxed, which should be the lowest amount of pressure. There are some factors that can contribute to the changing of the blood pressure, maybe extra blood volume, the cardiac output, maybe peripheral vascular resistance, if there is obstructions or circulatory disorders that cause the vessels to be smaller. So the elasticity of the vessel walls, the atherosclerosis, can affect the blood pressure as well. So we know that the blood pressure first thing in the morning, before people start getting up and moving around, is lower in the AM and typically higher in the afternoon. that caffeine, stimulants, alcohol, nicotine intake, exercise, emotions, stress, all those things increase blood pressure. We also would add that crossing your feet and your arm position, things like that, the body position, it's typically higher when people are standing. All those things can affect the blood pressure as well, including, gender, race, weight, the non-modifiable factors. So pain is one of those things that's considered a vital sign. We talk about pain on a scale of 0 to 10. We observe for comfort for the patient. And if they say there is no pain, we validate that as a 0. If they say they're having the worst pain ever, we can validate that pain as a 10. And if they do have pain, then we continue on with their cold spa or symptom analysis. In the blood pressure procedure, part 1, you're going to have the client sit with the legs not crossed, because we know that can increase the blood pressure, and the arm at heart level. You're going to expose your arm, and be aware we're going to measure this cuff around this arm. You're going to palpate the brachial artery or the radial artery, utilizing the radial artery in your procedure for your checkoff. You're going to place the cuff about 1 inch above the antecubital area. So be sure that when you wrap it, it's evenly around the arm. But you would have wanted to measure that cuff prior to putting it on the patient. And your width of the bladder of the cuff should be 40% of the arm circumference, and the length of the bladder of the cuff should have 80% of the arm circumference. Think about what you're trying to do. You're trying to utilize the air in the bladder of the cuff to obliterate the brachial artery. So when you increase the air through the bulb until the pulse is not felt, you are compressing that artery or obliterating the artery. When you do that, during this procedure, you're going to be pumping the bulb up while palpating. And you will palpate and make note on the sphygmomanometer when the pulse is not felt. You're going to save the number because you're going to utilize that for the next leg of your blood pressure procedure. Next, you're going to take your diaphragm of the stethoscope and place it in the antecubital space. This is where you're going to listen for the pulse disappearing. Now, you are going to release all the air out of that valve, and we are going to now pump the blood pressure cuff up again while you have your stethoscope in the antecubital space. So, while you're auscultating, you have the sphygmomanometer where you can see it. Now you're going to take the valve all the way to the right and then pump up with the bulb. You are going to pump it up until 20 millimeters of mercury over that last value. And then you're going to slowly release the air with that bulb valve, taking it to the left very, very slowly, about 2 millimeters of mercury per second. You're going to listen to when the pulse resumes. And when that pulse resumes, it's going to sound like a consistent boom, boom, boom. That beginning of that pulse is the systolic pressure. Now, your Korsakoff sounds include the systolic, which is the first audible sound, and then the diastolic, which is the last audible sound. Again, you're going to deflate your cuff 2 millimeters of mercury every 1 to 2 seconds. Your recording of your manual blood pressure is in even numbers. Each of those little lines on the sphygmomanometer are in evens. So there's no way that you can get an odd number, okay? So you're assessing also the pulse pressure. And so that's the pressure between the systolic and diastolic values. That's the pulse pressure. You will want to probably assess in both arms because sometimes there's difference in one arm versus the other. But for the sake of your checkoff, you will just do this in the one arm. So some of the errors in blood pressure measurement are maybe the cuff might be too small, or when you're blowing up the, pumping air into the blood pressure cuff, it pops open because it's too small. If the cuff is too loose, somebody moves their arm and it just falls down, that might manufacture an incorrect blood pressure. Maybe the arm position or the feet are crossed. So be aware of those things and how those might affect the blood pressure. There are some American Heart Association blood pressure guidelines. These things change all the time. So there are pre-hypertension, high blood pressure, um, and emergency care. Obviously, you need to know that the diastolic number being high is becoming just as important as the systolic number being high. Because you can think that if your vessels are never really relaxed in the diastolic number, that can be just as stressful on the body. We will also talk about orthostatic vital signs. So what this means is that a patient, when they stand, their blood pressure drops. And so as we talked about earlier in this lecture, that typically your blood pressure increases when you're standing. But when the blood pressure drops 20 millimeters of mercury or more, systolic, or 10 millimeters of mercury or more diastolic from sitting to standing, this is considered orthostatic hypotension. So your pulse increases to accommodate this, but this may be related to some other diagnosis. And we would talk and try to identify and correct some of these issues. The biggest problem with this is that the patient, this may cause them to be dizzy when they're standing up, lightheaded, and they are at risk for falls. And as most of you know, when a patient falls, they may injure another part of their body. So this can be a real problem. So we'll talk more about orthostatic hypertension as we go for peripheral vascular and your cardiovascular units later on. But this is definitely important to acknowledge. And sometimes you'll see where the doctor orders orthostatic vital signs, which means we'll take them when they're lying, sitting, and standing and see what the trend is. So let's talk a little bit about postural orthostatic hypotension. Just want to give you the background for the process, the causes, and treatments that we do out in the hospital. So just to understand that when somebody is lying flat in the supine position, the blood is evenly distributed. When someone stands and that blood is down in the legs, the blood pressure drops, right? So this drop in blood pressure is detected, and the response is increasing sympathetic and parasympathetic outflow. So the pooling blood causes reduction in the venous return. That makes it a little more challenging, right, for the venous return. And so cardiac output, that pressure falls as well. So it's not just that the patient's blood pressure falls, this impacts the whole system, right? We know that if we have decreased cardiac output, that is decreasing our oxygenation to tissue. So this is a significant situation when this is happening with your patient. And so as a result of this, peripheral vascular resistance is increased. Um, um, so this causes venous return, cardiac output, and blood pressure to increase. And so the body has to compensate for this, right? So when that mechanism is not working correctly, that's when we have these big drops in blood pressure. So if it's delayed or inadequate, like I said, this postural hypotension occurs. Hypotension means the blood pressure is low, right? So some of the causes may be the patient is hypovolemic, which means they have a decreased, less than expected volume, related to dehydration or blood loss. Diarrhea causes fluid loss in the body, diabetes insipidus. Some cardiac impairment like bradycardia, aortic stenosis, tachycardia, arrhythmias, myocardial infarction, which is, heart attacks, as you will know, and pericarditis, which is inflammation of the pericardium, the sac around the heart. Another issue might be vasodilation. So if somebody is standing for a long period of time and the gravity is holding that blood flow down into the legs, varicosities, which we know are inadequate veins. And so we know the veins have valves that send the blood back toward the heart. So if those are inadequate, blood tends to pool in the legs, right? So some of the non-pharmacological things that we do for our patients out in the hospital setting is, if we know that somebody is having orthostatic hypotension, we're going to assess their blood pressure medicine. We always check the blood pressure before we provide medication to make sure it's sufficient, because we know somebody has to have a sufficient amount of blood pressure to circulate the blood appropriately. So we're going to also assess their fluid and salt intake. We're going to evaluate their input and output. Make sure that they're not having alcohol in the hospital, I'm sure, but that if they have this problem out in the world, this might be something you would want to educate them on, would be important. Increasing the physical activity, we know the benefits of that with cardiovascular health. We're working these vessels, we're working these muscles, and preventing these issues. What we really try to do, if we know that the patients are hypotensive, we're going to have them go from a lying to sitting to standing position very slowly, because we know if they have a sudden drop in blood pressure, this may make them feel dizzy or lightheaded, and they could fall and hurt themselves, and that's obviously a big problem. We will have them tense their legs, do ankle pumps, which is the dorsiflexion, plantar flexion of the ankles, to get some of that blood flowing, get those calf muscles working, and help for any pooling that's happening down in the legs. We're going to lift their head of the bed up slowly, and ease them into the next change in position if that's something that we struggle with, just for safety. A lot of times we'll use these elastic stockings or the anti-embolism hose. We'll use the sequential compression devices where we'll squeeze their calves to keep that blood from pooling. We encourage them to do their own exercises and ankle pumps, etc. Now, if we know that they have fluid issues or dehydration, we may need to address their fluid intake, and there may be some other medications, but obviously we are going to try to do the non-pharmacological as nurses. Those are things that we are going to do. So hopefully this explanation helps give you a little more structure about orthostatic hypotension. Here's a list of some of the abnormal findings that you might see in your general status. These are not extremely common, most of them, but there are some things that you'll see relatively frequently. The obesity and anorexia, things like that. We need to identify these abnormal findings, and so we can address them and document to take better care of our patients. That is the end of this chapter, and thank you very much. In summary, in Chapter 8, what are the different pieces of the general status and the different types of vital signs? Do you know what are the major older adult considerations in general status and vital signs, including the observations, temperature, pulse, respirations, and blood pressure? Can you describe the steps of taking a manual blood pressure and including measuring the cuff and the patient position? And lastly, are you able to list any abnormal findings, including the elevation or the decreased temperature, pressure, respirations, pulse, and blood pressure, noting the values and the description of the diagnosis?